one time you may fuse a segment is if you need to take the pressure off the nerve roots, but doing so is going to destabilize the segment. So therefore you have to fuse it together. The other reason you may fuse a segment together is because it actually indirectly takes the pressure off the nerve roots. So by changing the orientation between two vertebrae or two segments, that alone can take the pressure off the nerve roots. And then I think, the last reason that we fuse the segments together is if we need to realign them. So this is in the case of what I would call a reconstruction or a deformity type operation. We'll fuse those segments together because we literally have to put them back in alignment. So that I think is like the third reason. The other reasons, could be trauma or, infection sometimes. There's a lot of other reasons you may need to fuse it, but those are really the main ones. So again, going through those. So the first reason you may need to fuse is because by decompressing, by taking pressure off the nerve roots, that's going to destabilize the segments, so you have to fuse them together. The second reason may be that fusing the two segments together alone takes the pressure off the nerve roots, and I'll show you an example of that. And then I think the third main reason is if you need to literally realign the segments in order to get the spine back into a more physiologic or anatomic shape. So the best way to think about it is that we can get the bones to heal together, to fuse, in really two different places. One of those places is in the back of the spine. That's called a posterior fusion. So we get the spine to fuse across these joints right here, called the facet joints, and we also get the spine to fuse across here, which are called our transverse processes, right? So that's one way we can get the spine to heal together. The other way we can get the spine to heal together is through the disc space. And when we get it to heal through the disc space, this is called an interbody fusion. A lot of times we'll combine both. A lot of times we'll do a posterior fusion and an interbody fusion. Now, it starts to get even more complicated once you start talking about the types of interbody fusions, which we'll get to in a second. So first of all, let's just talk about how we do a posterior fusion. So the way we do a posterior fusion is first usually, we place pedicle screws. Now what these are screws that go into the vertebral bodies through something called the pedicle. It's a safe channel, meaning that it's a bony channel and we can put a screw in there. Then we have the screws in. We will then put bone graft across the posterior parts, so across the facet joints or the transverse processes. And then we'll place a rod into the screws. And then we secure that rod with what we call set screws. And this secures the spine into place until the bone grows together. So all these things are, in a way, they're temporary, right? I mean, they stay in your body, but they're only serving a purpose until the bones heal together. Once the bones heal together, the screws and rod are no longer doing anything. So I think the next thing to talk about is what we call an interbody fusion. Now, an interbody fusion, again, is when we get bone to grow between the vertebrae and the disc space. Now, an interbody can be done in one of three ways. One way you can get to the disc space is from the back, okay? So in this case, we may go in the back right here, we move the nerve roots out of the side, and then we place a titanium spacer or cage. That's usually how we do it. You can do other things too, but we place bone graft and a titanium spacer. So this is an example of a type of titanium spacer that we may put in there, right? You can see that it's pretty small compared to the other ones. The other way that we can get to the interbody space is by coming in from the side. And this is called a lateral lumbar fusion, or what they call LLIF, L-L-I-F, lateral. So we come in from the side. So that means we make a small incision on the patient's flank or on the side of their abdomen, and we go through a muscle called the psoas, and we take out this disc or whatever is left of it, and then we put in a spacer. The last way we can do it is called an Anterior Lumbar Interbody Fusion, or an ALIF. So when we do an ALIF, that we actually come from the front. So some places the spine surgeons do this approach themselves, but in most places they have what they call a vascular surgeon or a general surgeon is what they call an approach surgeon. So that surgeon will help us get to the front of the spine, and then we can put in a really big spacer or cage by coming from the front. So this is an example of an ALIF type cage. And you can see it's much bigger than when we do what they call like a TLIF, or that posterior cage I talked to you about earlier. So each one has its advantages and disadvantages, but those are the three ways that we can get what's called the interbody fusion in the spine. Earlier I talked to you guys about how fusions can be done for different purposes. So if you remember, we said it's done when the spine is made unstable or destabilized by doing things like laminectomies. Sometimes you need to do a fusion with that as well. But the second reason I talked to you guys about was that by doing the fusion, that can create space for the nerve roots itself. So here's an example that I just wanted to show you. So if we look right here, right, I actually took this disc out right here. And we can see that by taking the disc out, the space for that nerve root, there's not much space for it. So a lot of times, I guess so, a lot of times when we do a fusion, or when we do an interbody fusion, we do it to give space for that nerve root. So for example, if I do an interbody fusion, let's say I come from the side, and I lift this up, you can see that that nerve root now has a lot more space. So that's just an example of why sometimes by doing the fusion, you actually create more space for that nerve root. The reason that you can't put like a giant ALIF cage in from the back is because our window is limited, right? So it's like when we come in from the back, we have to move these nerve roots out of the way. So we can't just move them like way, they have to we can only move them out of the way so much. That's why when we come in from the back, it's a small spacer. Now, there's ways you can get around that, right? So sometimes we'll actually put two spacers in from the back. And when we do that, so we might come from that side and that side to get two spacers in from the back. Deciding whether we're going to do a fusion only posteriorly, doing what we call like a posterior interbody, or what they call like a TLIF or a PLIF, deciding between that and going from the side, that lateral LLIF, or going from the front. A lot of times that depends on patient anatomy. Like, so some patients it's more favorable to go from the one side. Bone quality is a big consideration. If a patient has soft bones, you're going to want to try to get the biggest spacer in possible. And then the other things is style is a big one. If you just have learned a certain approach and know that one best, many people are just more familiar with one than the other. But I think most days, like a lot of, modern spine surgeons, like meaning like people that have been recently trained, like we're trained in doing all of them. And I actually think that one of the biggest questions like facing the field is figuring out, what scenario is best for which technique, right? Like each technique is probably somewhat like there are equivalencies among the techniques, and if somebody's good at one technique, it's, they're going to be able to get that done in that way. But figuring out who does best with one versus the other is, I think, still something that we haven't quite figured out. There's other advantages that are like a little more technical, like you can get alignment better using certain technique, or I shouldn't say better, but more reliably. You can get like certain alignment, meaning like getting more curvature is easier with one technique versus the other. But again, it's a lot of surgeon preference. But more than anything, I personally really try to use like the patient anatomy as my main guide. Patient anatomy and bone quality. So I do think that each technique has its advantages depending on the patient in the scenario.